Yeah, so the first item is public comments. Do we have anybody sign up?
I saw that, I saw
Yeah.
that.
Excuse me, but the meeting has started.
The next item on the agenda is the public comment. The public comments portion of our meeting is available to members of the public who wish to address an agenda item to be considered by the board on tonight's agenda. Anyone who wants to speak during public comments must sign in prior to the start of the meeting and list the agenda item they want to discuss. Each public comment speaker will be allowed a maximum of 3 minutes to address the board. Time limits allowed should confirm with the policy. If the board does not have any public testimony speaker who requires attendance will receive up to 6 minutes, allowed to twice as much time as the English. The public comment portion of the meeting will allow all speakers who have signed up before the start of the meeting to address the board at this time regarding an item on tonight's agenda. I ask that you not discuss students who are not your own child. Policy D, GBA, FNG, and GF are available for specific complaints regarding employee, parent, and community members' complaints, respectively. Thank you. Our first speaker is?
Alma de la Garza,
What do you want me to say?
on 2 health insurance.
You wanna go?
Over,
Yes, if you want. If you want to address the.
Okay. Good. Okay, good evening, school board members and Superintendent Asaiz. I appreciate the opportunity to speak this evening on health insurance. My name is Alma de la Garza, and I'm the local president for Ghana TSTA. For many of us, even if we can read websites and pamphlets, we are mostly lost when it comes to coverage and best practices for use of our benefits. For most of us, we probably don't give it much thought either. We just know we have health insurance and we are thankful for it. However, many have experienced surprises that they receive a bill for a balance owed for a procedure. We at TSTA continue to believe that a whole lot more needs to be done to provide information, and either by doing presentations or having informational flyers in English and in Spanish on some best practices to help the district and employees to save some money. This is twofold. We are educated on the different options and possible cost savings, and we may also end up dwindling down the amount currently allocated for insurance benefits. We also need to have staff available on site who can assist an employee with some basic questions and not just be referred to a 1-800 number. Helping the employees become informed will go a long way. I appreciate your attention and hope that our concern can be seriously considered. Thank you.
The next item is a health insurance discussion and presentation update by Gallagher.
Yes, sir, go ahead.
All right.
Mr. Duarias, thank you for coming for preparing this presentation for
Thanks
us.
for having me back. Good evening. My name is Luaris. I'm with Gallagher Benefit Services. And so what I'd like to do is kind of pick up where we left off. I didn't get too far in the presentation, but I want to kind of revisit that. Before I get started, what I will tell you is that these numbers have been updated since, and I'll go over what has been updated. And I included some utilization information and some graphs and pie charts. And then I also have some information that I didn't have last month in regards to your United Healthcare reconciliation and the runout, and I'll explain what that is. So if we go ahead and get started, and if I can't get this to move very quickly, I'll either stand up or we'll go by the handouts. There we go. We're going. I think it just has a little bit of a lag. Okay, so first things first, I'm going to talk about the plan overview. I'm going to talk about the financial monitor report from Blue Cross Blue Shield. I have claims data through December. Your January claims just barely missed the cutoff to getting them in here, so the next time you guys see me, we should have claims through February. And it'll look in a much different format because it'll be in our new system. I'm going to talk about some utilization reports that I obtained from Blue Cross Blue Shield as well as ESI for information through December. I am gonna revisit the previous plan year with United Healthcare with their monitor report, because it's important that you understand the run out and how that impacts your today's plan. And then you can kind of use that as a comparison to where we sit, in comparison to, let's say, December, since we have numbers through December on where we were last December. And then last but not least, the United Healthcare stop loss reconciliation, and that'll be something that I did, that'll be new, that was done in the previous handout. So with that being said, I'm just gonna revisit, I won't spend too much time on this because I did the last time. You guys currently with Blue Cross Blue Shield, you're with ESI on your pharmacy benefit manager, and you also have your stop loss with Blue Cross Blue Shield. You were previously with United Healthcare for medical, pharmacy, and stop loss, so you had it all bundled together. You still have two plans offered, a high plan with a $3,000 deductible with 80% coinsurance, and a medium plan with a $5,000 deductible with 70% coinsurance. And if you remember, those are changes that were made this year due to some hard decisions and some funding strategies that we put in place to fund correctly, start building a surplus. And then, of course, the district contribution of $505 per employee per month stays the same. Let me just stand up and open. So the next set is the financial monitor report for Blue Cross Blue Shield. Some changes that were here, that weren't on the last, or vice versa. The numbers that I showed the last time only included Blue Cross claims. What I did this time is I included the United Healthcare run out. And so when you turned off United Healthcare, they no longer pay claims, or they will stop paying claims after the end of this month, March. But that rolls, it comes from the, and we calculated that amount into what we budgeted for or came up with to roll into this plan year. And so that's why they're included in this exhibit here. But I also, you'll see that there's a separate page that'll just show you only the United Healthcare run out. What I also did, as opposed to putting what was budgeted, I put what the planned cost was at for that particular month, and then up to. I didn't compare it against budgeted for two reasons. One, I wanted to look at it this way because I want to talk about other things other than just budgeted items. And more importantly too, our numbers were off because we realized that Donna has a 5-tier structure on their rates that ties directly to what the employees contribute, but what's being reported is, or comes from Blue Cross, is only 4 tiers, so we were lumping 2 tiers together, and it was throwing the numbers off. So until I get that fixed, it's gonna be a manual process, so I removed that from here. But we'll get it corrected. In case you're confused, you have 4 tiers typically: employee only, employee spouse, employee child, and employee only, employee spouse, employee child, and employee family. 4 tiers. The way Donna has it set up is you have an employee only, employee spouse, employee plus 1, employee children, and then employee spouse. So you have 5 tiers. And we were lumping the employee plus 1 and employee children all together. And those deductions are not the same. So we were our numbers were not coinciding with Mrs. Cancino. She's the one that pointed it out, saying that your employee contributions are incorrect, so therefore the math was not coming out. It's a slight differential, but we're gonna get that taken care of. So I'd like to go ahead and start on this. I'm going to go through a quick example of what all these numbers mean for the most part, and then we can fly through it, because then we don't have to go through every single one line by line. But so you'll see numbers here. This is for all plans lumped together. So this will be your high plan and your low plan, or your medium and high plan. So the top part gives us the employee count, the head count. The head count changes from month to month, so some of the numbers may fluctuate, but that's because you had hired teachers that came on or came off, but it doesn't fluctuate by very much. So then we go to the members. I call those belly buttons. So the top number is employees, and then how many dependents or belly buttons are actually on the plan. So you have 3,400 in October. The medical claims are exactly that. As you guys know, you guys are self-funded, so you don't pay premiums. You pay a premium on stop loss, but you're more concerned on the claim itself, not the premium, because you guys are self-funded. So that'll be the claims. Right underneath that will be the pharmacy. They're broken out. You see that part where it says United Healthcare Shared Savings? Even though this is the Blue Cross report, remember this includes some United Healthcare runout. And when it says UHC Shared Savings, what that means is there was some out-of-network claims. And what typically happens to avoid some balance billing, United Healthcare steps in and negotiates a lower rate or brings that balance billing down. And in exchange for that, they get to keep a percentage of that savings by doing that for the employee. And so we include that in, and it's not very much, as you can tell, here in the grand scheme of things. Then we have the claims that are over your specific. I can guarantee you those are for claims that were with United Healthcare, because we're only 3 months into the program. We don't have folks that are that close or even close to the spec, the individual stop loss. And then that, you add all that together and that gives you your total claims. Then we add your admin fees. Again, those are your fees times the heads up on top. That's what you pay United Healthcare to process claims, to access the system, provide ID cards and customer service. This is the only premium you pay, and that's for your stop loss. This is the actual insurance. So you're self-funded up to a certain amount, $300,000 on each individual. And then you have aggregate insurance that covers not just the individuals, but when the group gets to a certain amount, then the aggregate insurance kicks in. That's the actual insurance of this program, and you pay a premium for that. And that's the $186,000 here. And it'll fluctuate again because it's based off of the head count up on top.
That's every month.
Every month. So this basically stays almost the same because it's based off of your head count. The claims are where you see the peaks and valleys. So yes, this is important, but if you look at the dollar amounts, it's a small piece of the pie in comparison to the actual claim. So you add up the claims to your fixed costs, now you have your total plan cost at $1.4 million. This is the only page where I throw in the employees' contributions. Again, it's going to be slightly off because it was based off of the 4 tiers, not the 5. So after you take what the contributions that the employees kick in, now the net employer cost is $1.1 million. The budgeted cost is the 505 times the head count plus what the employees pay in. And then you look at your actual cost. So for the month of October, you had a deficit.
Sir, you
Yes,
didn't
ma'am.
give us the comparison to the previous year, I don't see it.
I'm getting there.
But I don't see it in.
It's in here.
It is?
It is. It's not a comparison. It has last year's. So you would look at October and October.
October of
Yeah,
2018 to
Correct.
October
I
of,
see the one for,
Go to the,
I don't need to get ahead of you, I'm
That's
seeing
fine.
the other one, the other insurance that we had.
it's in here. Well, that's it. The other insurance you had is United Healthcare, and you compare.
Okay, it's because I guess I'm looking at the reporting date, September the 30th, okay, 2019, so
Yeah.
it would be this one.
So what I can do the next time when we start doing this, and what I can do is put the months right up on the same page, so you can just do a quick comparison instead of flipping through pages.
There you go.
The system that we're gonna be using automatically does that for us.
so
And
you
so-
could do like,
So when you see
September
October,
to-
November, December, January, February, you'll see this year and then last year's
And,
underneath.
yeah, and
And
do
a
it for
comparison.
both medical and pharmacy
Mhm,
and administrative,
correct.
those three, so. by month.
So in October, you had a little bit of a deficit. Again, these numbers changed because I did include your run out from United Healthcare. United Healthcare claims that are paid, they were incurred prior to October 1st. But as you know, unlike pharmacy is real time. When you go to the pharmacy and you pay your copay, it's electronic, it gets paid right then and there. Whereas on the provider and hospital side, they have to actually file the claims sometimes electronically, sometimes paper. Sometimes things get held up because it wasn't, it was declined or asked for additional information. There's a whole
Yeah.
myriad of
it
reasons.
takes a while to get paid.
There's a lag, and so that lag carried over into this year, okay? So, that being said, if you just look at November, that way I don't have to go through all of them there. Let's look at the stuff that matters, right? So for medical claim payments, for November, it's $422,000, your pharmacy was $387,000. Again, all these other numbers here stay pretty similar because they're fixed costs. And if you look at the bottom against what was budgeted, again, all plans combined, you had a surplus of $275,000. If we do the same thing for December, we'll look at the claims, $634,000 on the medical, $310,000 on pharmacy. Go to the bottom line, compared to what was budgeted, you have a $230,000 surplus for December. If you go all the way to the right, what we're looking at is, right, as for December, you have just under $500,000 of a surplus. So you're running in the black, not the red. Now this can change, right, because you could have a bad month, and I'll start going through some of that information here, because I did.
January and February are the peak months for high costs.
Good point. December, usually November, December, and January are your higher utilized months for obvious reasons. Vacation, end of the year, beginning of the year, deductibles. But those are usually your higher utilized costs. And then again in the summer, because people have more time to do scheduled procedures. Okay? So let me go ahead and flip the page. Are we using the screen, or should I just use the handout? Are people looking at the screen?
It's too small.
Okay, then
Yeah,
let's use the
this-
handout.
I
Okay,
can't
because it's
read
not moving along with me. So let's flip the page. Now I did a quick summary on the other side, just to kind of, so what do all those numbers mean? Of all those numbers that I talked about through December, 47% of your cost is for medical. So everything but pharmacy. 30% of it is pharmacy. That's about where most folks are at. We used to see pharmacy around 15 to 20%, but now with the advent of a lot of these newer drugs, specialty drugs, we're starting to see pharmaceutical percentage creep up 30 plus. So you're not alone here, but 30 is still high. And I'll explain why here in a little bit and what we can do. 8% of the cost is your fees. I said it's not, I mean, it's money's money, but it's a small piece of the pie when we're talking about the total health plan. And then 15% of it is your premiums for the insurance part, the stop loss. So combined, your plans right now through December are running at $459,000 in the surplus. Now we'll break it down by plan, but here we're just gonna talk about what the actual plan cost was. We're not bumping it up against a budget. So again, for the high plan, the medium plan, you have 1,900 employees in the medium plan. That's probably where the majority of your employees are at. And that's because that's the plan that the district contribution covers a good portion of it. I think the employees only pay like $25 and change, like 25, 44 or something like that. So they have the bulk of the employees on the medium plan. If we look at the medical claims, on the medium plan, it was 161,000, pharmacy 158, it's getting blurry. But then we go down, it's 575,000. If we look at November, it should coincide with a little bit of a spike because as we went through on the first page, it did go up 252,000, and then 307,000 on pharmacy. Total plan cost 818. And then December, no surprise there, December is a very highly utilized month. 423,247 on pharmacy for 928,000 total. If we go all the way to the right, your medium plan is running, total expenditures through December is $2.3 million. And that's for your medium plan. And that's where the majority of your employees sit. If we flip the page, same exercise on your medium plan, of that 2.2 or 2.3 million, 36% of that is medical. 31% of that is pharmacy. And again, these are the smaller amounts, 11% ASO, 22% of the stop loss. So the total cost for the plan on the median plan is $2.3 million. Let's keep going. Now we're talking about the high plan. You've only got 210 people on the high plan. These are folks that are willing to buy up to the lower deductible. There's two schools of thoughts here. People will buy up because maybe they're a little nervous of the deductible and they'd rather pay now out of their paycheck via a deduction than as opposed to later when the services are rendered because of the higher deductible. Or these are the folks where you might find your chronically ill folks because to them it's worth paying extra to use a plan with better benefits because they are the ones that are probably going to use it the most. But you could also have people that are falling in that category that may not have the extra money, the income to pay for the higher premium, and you still might find some of those in the medium plan. But our experience has been if you buy up, you're buying up for a reason. So the numbers get smaller here. Medical claims are only 39,000. That's the other thing too. So when you have only 200 people on a plan, it doesn't take much to put this plan in the negative because you could have one or two people because you don't have a bunch of numbers in there. And that's a different conversation about how you price plans based on numbers also, because you could have 2 or 3 people with 2 bad months that could put this plan upside down. So pharmacy is 65,000. The plan is running at 132,000 for October. For November, it went up to 202,000. And December, it went up to 222,000 as well on your high plan. Your high plan is running at $557,000. The breakout there is 47% of that is medical, 38% of that is pharmacy. Again, these are folks that bought it for a reason, right? 5% of this is admin fees, 10% of this is stop loss, and then 557,000 is what the plan is running at. So before I move any further, does anybody have any questions yet? Because I still got to talk about UHC. I'm going to talk about some utilization reports. Then I'm going to talk about some things that we can do, being proactive. That's the advantage of being self-funded instead of being fully insured. When you're fully insured, you kind of have to wait until the year runs out, and then the only changes you can make is plan design. Being self-funded, you can look for trends and do some work and then find out if we can make some changes, but then how many people does that impact, and is it worth making those changes? But I'll talk about that a little bit down the line.
Mr. Arias,
Yes,
is
ma'am.
there a norm in the industry for school districts that are self-funded for the employee contribution percentage versus the net employer contribution percentage?
To the the employer,
Yes, employee to employer.
there, you mean the percent, the difference, the
Yeah, because
spread?
I calculated here in the district, the employees are paying 0.175%, while the employer is paying 0.825.
That's sort of the norm. We just went through an exercise, I try not to go too off topic, but when we go through, when we start talking about budgeting, we're gonna show what we think your renewal, what you should fund for going into the next year. And we show very clearly, this is how much your plan is running at. I think this plan was bumping up against like 20 million or 21 million. And we'll say, based on trend and what's happening, your plan next year is gonna go either up or down, most likely it's up. Because of trend, just the inflation, but we can help offset that. And then we break it down to say the employer is paying 39 million of that, or I'm sorry, 15 of that 20, and the employees are paying this much. Now, what's the rate action to level this out? Because if you do nothing, then now you're gonna continue in the red. And so we start to play with numbers, and so do we increase the employer portion to a higher percentage? Or what happens if we increase the employee portion to a higher percentage? Which really a lot of school districts don't like to do, but we show it. It's our responsibility to show you everything. Even if we say the district will incur all of the renewal increase, the employees will take on all of the renewal because the school district's tapped out and can't contribute anymore? Or do we find a happy medium and split it somewhere? And we always show what that looks like for both the employer, the employee, and the employee contribution part. And then the only thing left after that is making changes to the plan. Because you can make changes to the plan, but if you're in the negative, the changes, I think we all know here, don't get better. You start making changes. We would not change your deductibles again. They're already too high. So now we're starting, then you get into the conversation of lowering costs if we need to. You start going to different types of plans. HMOs, Blue Cross is coming back in the valley very, very aggressive with HMOs again. The reason people don't like them is because they got a bad rap from many years ago, but their particular HMO is a gated HMO. Do you guys understand what the gated HMO is? It's where you have to pick a primary care doctor, and that primary care doctor directs the care and refers you to a specialist. And because it's tightly managed by a primary care doctor, in exchange, Blue Cross can lower the cost of care. They'll pay the hospitals and the providers less based on a capitated amount and reward them for their outcomes. But the reason employees don't like it so much is because it narrows the network. You have less choice. So that's another way you can do the same thing with pharmacy when it comes to the formulary. I'm kind of getting into the weeds here. But so to answer your question, ma'am, yes, we can show that. This is the norm. The norm is, especially in school districts, the ISDs pay the biggest chunk of that. And every year when there's increases, the ISDs find it very difficult to increase the employee's contribution.
Actually, in general, I think, compared to the valley, I think our rates are extremely low compared to other valley schools as far as the employees
Mhm.
portion. They're much higher in other districts that we study.
Correct, so you
And then-
can look at,
And going back to your options, we're hoping to go with option D, because I think you said 3 options, that you'll be able to reduce our expenditures.
but I can tell you how we do that. I can tell you how we do it, and it's not always a pretty picture, but it's a decision we'll make. But I'll explain how that works. Because there's really only a couple of options on how to reduce expenditures.
Some of the other districts, they don't, the district doesn't pay for any of the families. You know,
The norm is really that the districts that I've worked with, and even coming from our other book of business, is there are some districts that are, I don't wanna say generous, they may be financially in a better situation to help subsidize paying for children or the spouses, but the majority of the districts only contribute to the employee, which makes it very expensive for you to add a family member.
Wesco, I think that the cost is so high for a family member. 800 for a spouse, give or take,
That's
and
about right.
maybe 500 for children, and there's like a limit. Mercedes is the same, and I don't know about PSJ,
I just came from there.
but all of them,
Their contribution is very, very high, but that's, some school districts can contribute a lot more, but that doesn't always mean that their plans are better. It means that they're contributing because their plans are running very badly, and they don't wanna pass the cost on to the employees.
Is there any way that y'all could give employees the option, like, for example, I wanna have maybe a $1,000 deductible, but this is what I'm gonna have to pay out of for me? Or, you know what, I don't wanna pay as much, so I think I can go with a $5,000 deductible.
So,
Kinda like they do with that house insurance and
well,
car insurance.
it's very similar to what they call the market, the exchange, the federal government exchange. If you ever had to shop the Obamacare, they show you, it's like an exchange, they show you the platinum plan, the gold plan, the bronze, the silver, and the bronze. You get a bunch of options based on what you're willing to pay for.
Is that something that could be?
We do have some school districts that do that, however, I'm starting to see a trend where districts are starting to limit the number of decisions employees make rather than expanding it, and there's 2 reasons. You have 2 plans now, and ask any enroller, anybody who sits with an employee and is trying to make a decision on which plan to go based on their own personal, it's hard to pick when you only have 2. When you throw 5, it really kind of gets people a little anxious, because they
Yeah,
don't,
no,
they're not have to.
I don't think 5, I mean,
Well, we
and
can
it's,
even do 3.
and
3
it's
or 4.
basically like when you have house insurance, you can go with a 1% deductible
Sure.
or a 3% deductible.
The other danger there is if you're gonna do that, which you can, you have to make sure you price it accordingly. Because if you put a $500 deductible out there, it better be priced, the gap needs to, otherwise, one person on that plan can blow up, you're gonna have what they call, you're gonna be negatively selected against. All your sick people are gonna run to that plan, and the others are gonna be subsidizing that plan, unless you price it appropriately.
That's correct, it has to be priced
It has to be
appropriately.
priced appropriately.
I agree.
But we can show that option this next time around. I wouldn't go to 5, maybe we show 3.
What was it before, last year? What was it,
You had the 2 plans.
but what was the deductible?
It was 300 and 750,
450.
450 and 750. Yeah.
The deductibles before were 450 and 750?
For individual,
Wow,
but
that
for
was
families
low.
more.
and that's why
But that's how we ended
we're
up-
getting a lot of tests done, and that,
Yeah.
and the district was losing money because, you know, all the other insurances,
Yeah, no,
I mean, you practically have to do a peer-to-peer every time you order an MRI,
correct,
and they'll deny it. You
right.
know, even though you spend 30 minutes on the phone talking to whoever is a medical
You've
director.
probably experienced this
I
firsthand.
says,
Yeah.
why even do a peer-to-peer? It's 30 to 45 minutes, and it's after you explain, and you've already faxed all your notes and documented. They'll say,
That's fine.
it's no, we're not gonna approve it.
So,
it's like-
I'm gonna go down a road I probably shouldn't, but just for the sake of the conversation, you're self-funded. You guys can do whatever you want there and remove that, but if you do that, then everything gets approved and the costs go up. Or we try and find a happy medium there.
Well, that's why, you know, when the deductible was raised, it's like, okay, do I really need this test done?
It
And they'll
changes
get
buying
it done.
behaviors, correct.
Yes, it changes the behavior, because before, they were just over like demanding. I want an MRI of my back, of my neck. It's like, you know, that's very costly.
So let me just
For
throw this out.
whoever's paying for it,
Mhm.
it's very
It's very costly.
expensive.
Because it goes straight to the
But then on the
deductible.
other hand, we don't want employees not to take necessary tests that they may need because they can't meet.
But that's
because of the
where-
deductible.
where-
So it's like a balance.
You gotta
It's
find
a
a sweet
balance,
spot.
and that's where, you know, raising the deductible makes them think, you know, do I really need
it or
to?
not?
And they'll find
Yeah.
a way.
So the way we're talking now, which was brought up during the committee, because several committee members did bring it up, and that's when you start talking about high deductible health plans with an HSA account. And so basically what that means is, I'm willing to take a high deductible, let's say 7,000, 7,500, even 9, no copays for anything, everything goes to the deductible. Right, so if I don't go to the doctor but maybe once or twice a year, so I'm gonna have to come out of pocket for 2 doctor visits and some medicine. But in theory, that plan premium should shrink tremendously. And it creates the change in buying patterns. So let's say you were paying, I'm just gonna throw some numbers out there. Let's say you were paying $200 and we do an HSA and it's only 100, just to keep the math simple.
Which is HSA?
Health savings account.
Okay, yes.
And so you could say, I was paying the 200 anyway, I'll put the $100 that I'm saving in this health savings account. It's my money now. It's not a use it or lose it, like the flexible spending accounts. It's mine. And so if I go through the whole year and I don't use it, I have $1,200 in that account that's mine to help cover some of the cost of that deductible. So when I do have that one doctor visit, I can swipe my card, or I can save it and pay out, you make a decision.
HEB has that.
A lot of groups have
A lot
that.
of
The
groups have
schools are a little behind on that, and here's why. Schools like to give very rich benefits, and rightfully so, right? The salaries to compensate for, you give the better benefits. And when you have a rich benefit, to go from a rich benefit to something like that, it's scary. So Harlingen ISD did put in a high deductible health plan. Only one person enrolled in it. And there was 2 reasons for it. We didn't have enough time to educate, because you do have to educate people on how to do it, but a lot of them were scared. And they're gonna wait to see who gets on it and how it works. And then you have to stay on it the next time around. We have to re-look at how we're gonna price it. The other thing that gets people interested into something like that, and again, we would need to put Donna in a financial situation where that could be possible, is the employee can contribute to it, but the carrot would be, hey, employee, if you take the HSA, the district will contribute, and I'm just gonna give $50 a paycheck for taking the HSA, because I know you're gonna make a very different decision on how you're gonna utilize care, because now you have to pay for it. And by the way, that is your money that we're giving you in that account. If you leave the district, that money's yours. It's very similar to a 401k, but you can only use it for health, dental, vision. You can use it for anything like that. But in theory, that's how those types of plans would implement. We did have some interest. People were asking about it. It was a little late in the conversation for us to consider it, because there's an education process that goes with it. But that is also an idea. I've got some school districts that are contemplating using that as their base plan.
I was thinking more like $1,000, $3,000, and $5,000 deductibles. And priced correctly, you're right, because that's gonna be key to, for our finances.
Right.
But I think that puts the decision more on the employee now. Okay, you want less deductible, less office, it's gonna be a little bit more costly
Okay.
for you. But at least we're giving them the choices.
We can do that, and we did do something very similar to that this last time around. Because I showed them a couple of options. I said, what do you, here's a plan that keeps your deductions from your paycheck the same, and here's what it looks like. Here's a plan that tries not to raise your deductible so high, because we're going so high, but you pay more for it, but you're willing to pay more for it because you'd rather have the protection now, pay now, not later. And then we found one in the middle. Overwhelmingly, the employees wanted their deductions to stay exactly the same.
Right, but I think the well, I don't wanna say miscommunication, I think maybe the, what wasn't emphasized to them was, hey, your deductible is gonna be 5,000.
I
I think
think
that's
they were
what
aware.
was-
They were.
aware.
We showed them all 3 side by side, and they still chose to take the money home in their paycheck as opposed to giving
That
it,
was the reason.
putting it, because we did give them the option of picking plans with lower deductibles but paying more.
Have you by any chance have you run any reports that places, how many employees last year we had that hit the 5,000? That would probably be affected now?
Well, so last year you had people that only went to, what, the 400 and the 750,
But
so,
yeah,
but we
running
can
it
run something like
Like a
that.
5,000, like how many employees would it?
So here's what I can do that might be helpful. In addition to what I'm doing here, I can add every month the percentage of employees that are at 25% of the deductible, 50%, 75, and 100%.
Yeah.
Because here's the reality, if people aren't getting anywhere near to the $5,000 deductible, then the $5,000 deductible shouldn't scare anybody anymore. Because if you lower it, what would prompt you to maybe is if you had a bunch of people meeting that $5,000 deductible, basically all you did was cost shift that other exercise. Instead of having them pay more in their paycheck, you just cost shifted it to them if they needed care at the time of the care. But I can certainly run that report so they can see if there's a trend on how many people actually hit their deductible. And that would be also very helpful for employees, because if I'm buying up, but I'm not using the plan, why am I paying extra for it?
Exactly, they could be putting that money into a savings.
And this deductible kicked in October, right?
Correct.
This new plan, so we still.
You'd have 3 months. We might have we don't have a lot of people that are near the $300,000 threshold on stop loss. So I can't imagine there's people that have gone through, there might be a handful.
Don't change.
And I guess that's the number that I'm trying to figure out, how many people are being affected by this high,
We'll look at that.
Deductible.
We'll look at that and I can run those.
because it's
yes, sir.
different if it's 800 people versus maybe it's only 10.
Okay, yeah,
See,
Understood.
that's
point
one.
taken.
But I like the idea of like looking at another option, like maybe with $1,000 deductible. I think for next obviously is too late.
So I think the option that we put out there was 2,500, because if we went to 1,000, the pricing was gonna be really outrageous.
Yeah.
Yeah, but the other thing is, there was gap insurance that was added, right? So some of our staff members signed up for the gap.
So did they add, I don't do any of the ancillary, so that's a
It
good
was
point.
added, right?
Okay, so that can also help
How many
employees.
of our staff members get the gap insurance? Because the gap insurance was to, you got the number? Okay. Yeah, because that will help offset, if
Correct.
the deductible, right?
Right.
The high deductible.
So we would also probably ask for them to run a report, because if somebody has it and has been paying for it, but they didn't use it, then they're paying for it that year. It's a crystal ball. I don't have a crystal ball. So you had a good year this year, does that mean you should dump it next year and then you end up having something? But they can make that decision on their own, if you give them the information.
All it takes is a catastrophic motor vehicle accident, which is happening multiple times a day.
You don't see it coming, right?
Yeah,
Yeah.
and that person's in the hospital and rehab and.
So real quick, just to get back to this is your UHC runout. UHC is gonna continue to pay claims through the end of March. But for services that were only incurred through the end of September. So after that, you won't see this anymore. It'll just be the claims that are coming 100% from Blue Cross. In the event that there's a claim that comes through after UHC stops paying for the runout, we'll handle those on a case-by-case basis, and we'll get a TPA that'll reprice the claim for a negotiated rate, and just pay those based on as they come in. Because what United Healthcare was proposing was they'll pay for the rest of the year, but it was $87,000 just for the admin. What if we only processed 20 claims? So,
Not worth it.
so we decided to go this route.
So this runout, is it included over here on the all? Or is
Correct.
it is?
It's included just now.
Okay.
That's why the numbers look so
You
much
just said
higher from the last time. So I did include it. And then I did a quick scenario, cutting up the pie, how much of that was based on diagnosis. So this will be interesting, right? So top 10 diagnosis by amount. So your neoplasms was number 1. Symptoms and signs and factors influence health status. That's a very broad and vague category, which means it could be a myriad of a bunch of little things that a bunch of people had and they all went to. Then you have diseases of the circulatory system, and then injury and poisoning. Those are top 5, and then disease of the respiratory system. Those are your top 5. And if you go to the right, you can see what that equates to as far as percentage of total claims, and then the amounts that were paid. Now when I show you the pharmacy, it's going to look very different, because you would think that, oh, well, if cancer's are number one, then you would think the cancer medications are also gonna be number one, and they're not.
Oh.
They're gonna be, it's very surprising what is number one. Maybe not so much to everybody here, but, so if we want, we can go ahead and, now we're only looking at, some Blue Cross utilization reports, just to kind of put some numbers to those dollar amounts. So here, I have it broken down. This is, an overview. So the facility, so for facilities, so inpatient facilities, this is stuff that goes to deductible. Because co-pays usually cover the office visits. So you had $1.2 million that were covered. You got an $869,000 discount because of Blue Cross's negotiated rate for those particular providers, which equates to about a 68% discount. So let me stop right there. So UHC is probably the biggest, it is the biggest in the country. Blue Cross is up there. But when we did the analysis for the RFP, when you look at, we asked them, all the carriers, run last year's claims through your system and prove to me what your discount is. Because they'll tell you all day long, oh, we have a 68% discount. Well, 68% of what number? Right? $5 or $100 for a procedure. And so we asked them take real claims that were run by UHC. We already know what UHC dollar amount was. So we said, run it through. And that is why when we went through the analysis, Blue Cross Blue Shield was ahead. They were $9 million less than what United Healthcare would have charged you for the same claims. And so when they say they have a 68.6% discount there, that's because of the negotiated rate. This does, it's only 3 months, so let's not get, we can see how it continues, but we start looking at that number and check it against what they told us it was gonna come out at. And I will tell you that they are gonna come very close, because since they have the stop loss, they're the ones that are on the hook for anything over that $300,000, they start paying. And anything over the 21 million or whatever your maximum attachment point was, they start paying. So it's in their best interest to keep it below that, otherwise they have to come out of pocket. So that is one cost measure that we did by doing it, was making sure that we ran the claims through and that they showed that it was gonna save just day one. Now, that's assuming that claims were very similar to last year. And we don't know what's gonna happen, right? That's one thing that no one here at the table has control of, and that's the utilization, how often it's gonna be used and what it's gonna be used for. So we paid out Donna paid out $236,000 after the discount. It's a huge discount. Look at what was covered, and then look what ultimately ended up coming out the other end after discounts. And so that equates to about 13.9, inpatient hospital. If we look at outpatient, so these are your day surgeries, MRIs, stuff that's not, you're not staying in the hospital for more than 24 hours, they can't bill inpatient. 4.1 million was covered, they discounted at 2.9, the discount was 71%. What was paid was $666,000, or 39% of your cost is for outpatient services. And then your professional services, that's gonna be anything other than hospital services. So covered was 3.1 million, discount was 2 million, discount was 63, you paid 801, that equates to 47% of the charges. Those are your day in, day out, primary care visits, specialty visits, lab work, et cetera, anesthesia, phlebotomy, radiology, that's not billed through the hospital. And then just going down to the bottom, this is a good number to look at. How many people went out of network? Hardly anybody. Only, there was $152 of it was an outpatient that went out of network. So one thing you can definitely tell is that your employees are staying in the network. If we keep going, I'll try to speed it up a little bit. Here's just inpatient hospitals, the number of claimants, so those are the number of actual members, and then the number of visits for those claimants. So you might have 11 claimants, but you only see 10. One of them may not have was admitted and stayed inpatient. And then how much was actually paid? $119,000, and then we kind of average it out. It equated to about $11,000 for each admission. And then it shows you where they're going. They're in network, but these are the facilities that are being utilized. Any questions? We'll keep going. The back side of that, I like to look at this, we won't spend a ton of time, but this is the emergency room. Emergency room services are starting to creep up everywhere, and that's because wherever there was a Blockbuster, now that there's one of those 24-hour,
That's a good one.
you know, they're everywhere now. They're needed. I mean, it's nice to go to something that's other than an ER, but some of those places are an ER,
And they charge.
and they charge
charge
hospital
more.
prices.
A lot.
You need to look for urgent care centers. But some of them are it's hard for an employee to decipher between the two. And the way they find out is when they get the claim, it's $8,000 stomach flu instead of.
So could you come up with a list of the urgent care clinics?
United already has that. So what we need to do is educate employees to say, you need to use either the app on your phone, the web on your
So you're
computer.
talking about United?
No, not Blue Cross.
I'm sorry, Blue Cross.
I'm like-
I'm sorry,
Other,
Blue Cross.
no.
Somebody yelled out, well, glad somebody said that. It's Blue Cross.
Okay,
But they have it broken down.
but I mean, to educate.
To make it easy, like a one pager, every employee gets the one pager.
Yeah, I don't see why we
right
couldn't just
here.
go to the
There you go.
website and do a download of that
Cause that's
urgent
extra
care.
steps for the employee, one pager. Like,
Yeah,
just
yeah,
have it
for our
available?
blue collar workers, they need something simple.
Yeah.
You're
Why don't
talking
you put it
about
on your
apps, we're gonna be
refrigerator?
looking
The,
at.
Yeah,
the
that's a
kids
good
use
idea.
the app, the young
A
people
magnet.
use the app, but somebody with a flip phone,
Correct.
they're
So
not.
we'll do that. The only drawback there is, there will be a disclaimer on that.
We're
is
not
they need-
promoting, yeah.
Well, no, not that you're not promoting it, but somebody could go and last month that clinic may have come off the network and now they're out of network. So we might wanna have to update this every once in a while if we're gonna rely on paper.
Well, you can always say, these are right as of
The
today,
date, yeah.
and they can change.
But it is
this
helpful.
This is, where you can look for current,
Sure.
you know, and put where they can, you know, have somebody help them get it.
Right, and again, don't get me wrong, I'm not here to beat up on the providers. It's a business and everyone has a choice as to what they're doing. We're just trying to educate employees so that they know exactly what they're going to,
But
and
you
it's
know,
not what they think it is.
All the insurances, all of them want anybody to not go to the ERs for simple things, because they're getting charged. And we're all graded as providers. You're over your 80K, you know, you're over this, you know, you have so many, you have to meet national thresholds. You're above, you're costing us too much, and you get penalized. You maybe kicked off the insurance
Right, the
list,
network.
and they don't wanna be paying.
But guess what?
And we don't have control, but you have to constantly, don't go to this ER, use urgent care, use the night clinics, you know, there's
When we
night
run
clinics.
that list, you'll be surprised how many of them are not in network. They have a sign that says, we accept all insurance.
Yes,
You know what that means? We'll take Blue. We might be out of network, but we'll take it.
and you're gonna get
And
billed
you
for
think
it.
you're in network.
Mhm.
Okay, so ER, here's what we see for ER through December. Actually, this is through January. Blue had it through January because they get, since they see the claims before we do. So 34 for injury and poisoning. I won't go through all of these, but you can see what they're going for. What we want to look for here is what we call non-emergent. Stuff like flu, cold, you know, so it's not being used as a clinic. And I know it's hard to think that maybe an employee would do that, but here's the reality. ER, there's a steep copay, and then a lot of it goes to deductible, and the majority of the emergency room physicians are not in network anyway,
Right.
with anybody,
With anybody,
right?
and they don't
So there's
care.
always balance billing, right? But even if it goes to deductible, when the claim comes in and it gets processed at a deductible, the employee gets credited towards the deductible, whether they paid it or not. It gets credited. And so now they can keep going, and eventually they've met their deductible, whether they paid it or not, doesn't matter, they get the credit. And then in ER, they cannot be turned away if they have an outstanding balance, because it's an emergency room. So they can quickly start to use that as a clinic, and the problem there is once that happens, guess who's footing the bill once the deductible's met?
The district.
Donna ISD. And that's why we wanna look at emergency rooms, start encouraging people to use telemedicine, because I know you guys have that benefit too, that's another educational tool.
I've had some not so good outcomes with telemedicine.
It's not for everybody.
It's not, I mean, I've had patients try it and, you know, they gave them, by the time they got the medication, it was Sunday afternoon, they ended up in the office. Cause I have pink eye and medication was sent in and then it was out of stock, cause they prescribe something that we don't normally use, and, you know, so patients have unfortunately had not so good results with telemedicine.
So we can take a
But
closer
then
look
some
at
of
it.
them do, you know, use it, but then they end up at the office and they say, well, you know, I have to pay a copay anyway,
I
right?
think a lot of it's the Band-Aid to prevent them from going to the ER, and then eventually they'll get into their primary care, so they can, like you said, they eventually end up going.
I
But when you-
wonder where they get these doctors to do telemedicine,
we can ask vendors.
you know, to say, are they credentialed? I mean,
They are credentialed. A lot of the
Like-
times, they're PAs or nurse practitioners that are working under the umbrella of a physician.
They use medications like, we haven't used that in 20 years.
Almost 20 years.
The
So what we can do is
compliance, like-
we can do one of two things. We can make a decision that it needs to be promoted more so people utilize it, or say it's being underutilized and stop paying for it.
Yes,
Because the district's paying for it whether they use it or not, there's a fee for it every month.
yeah, if they're not using it, then why even?
Maybe rechannel that to something else, or we do another educational on primary care doctors. Do you
There's
have
a
one?
lot of clinics opening up, like, private, independent clinics that are working on Saturdays and some on Sundays.
Okay.
That, like, Dr. Peña, he has his mid-levels working on, and I've had patients go there, and then they follow up like a week later.
Like I
In
said-
Wesico also,
Right.
and Mercedes,
McAllen too, I think.
in McAllen.
Like I said, we're not here to demonize any of these providers, we just wanna make sure people have the information so that they know how it's gonna impact them financially, but also how it's gonna impact the district financially. Okay? I'm gonna go to the ESI. ESI is your pharmacy benefit manager, that's your pharmacy vendor. So what I did is I took a script count, this is through January. There were 5,200 generic scripts written. It came out to 167,350.77. We average it out, it's about $32 per script. The thing here is that there are some pricey, not all generics are very inexpensive. There's some generics that are very pricey.
Very expensive.
Yeah, you would be surprised as to why they're generic. The way you can tell a generic is you probably can't pronounce it, because it's the chemical name.
Yeah.
So if you have a brand name drug that everybody knows, Humira and Lipitor and all that, it's because they did it so people would remember it. But once there's a generic, it's the chemical name and you probably don't remember it and it's hard to pronounce. But they're out there. But we had 5,200 scripts written. On the brand name side, we had 2,069, 1.1 million. Big difference. Average script went from $32 to $542. So right there is an opportunity to start looking at making some changes if it continues this way. I'll keep going and then I'll tell you how we do that. So if we look at the month of October, we break it down by month, script count, and then we look at the generic fill rate. Your generic fill rate should be closer to the mid to high 80s. We're at 76.1. In November, it went
These
down.
are for chronic medications,
All
maintenance medications?
Everything. In January, it went up to 80. We'd like to see that 80 plus. Now, what drives all that? Oh, let me keep going. We were talking about this earlier. And then of those drugs, you have 2,000 of them that are single source brand names, but only 44 multi-source. That right there tells a story too. So here's what a single source. So new drug comes out, it's a brand name, no generic can be made for, I think it's 7 years, right? And then once it's 7 years, then other companies can make the generic equivalent because these companies want to recoup their costs for the research and development since they came up with the drug. And then after that, there's a generic equivalent available. We have brand names for particular drugs, and they have a multi-source. I'm just gonna make this up because I don't have them handy. Maybe I'll come with some real examples. But let's say you're taking a Humira, anti-inflammatory, very expensive. That's not the only brand name drug for rheumatoid arthritis. So there's a multi-source brand. There's another less cost-effective drug that's still a brand. Not forcing anybody to be generic, but it's still a brand. And so there's multi-source brands. Single source brand means that there's only one option for that brand name drug. And no one here, except for maybe you now, can make the decision as to which drug the employee should take. That's between the employee and the doctor. But when you compare that to how your plan's gonna cover it, then you have a discussion, do I want a generic or do I want a brand? You notice that sometimes you go to the pharmacy and they don't give you the option for the generic, and then sometimes they'll ask you if you want the generic. And that's because the doctor made a decision based on your plan of treatment that you should have this particular drug because maybe the others aren't as effective. You have allergic reactions to some of the dyes and fillers. Sometimes it's as simple as the brand name drug has a bigger dosage pill, and if we went to the generic, they'd have to take 8 of those pills.
Compliance
And
is
who wants
very
to?
poor
Right. And then the packaging even has, sometimes the packaging has to do with it. But so all of this tells a story, so what we're seeing here is we have some multiple source brands, but only 44 people are using it. And then if we look at the generic fill rate, it's not that high. So I will tell you that on the ESI formulary, that's the one thing, because of the changes that we made on the medical plan, we tried not to touch the pharmacy as much. We left the copays exactly the same because the employees were already gonna deal with changing the medical plan. So we made a decision to leave the copays exactly the same. We
And on
left the,
diabetes, I know that, you know, we're always faced with,
wait till you see one of the slides I have here on diabetes.
oh, okay. It's because they all want us to use the generics, and the generics like glyburide, well, you know, it's not gonna work anymore when somebody's been diabetic for over 10 or 15 years.
So I'm glad you're saying this stuff because
And they're just as expensive generic because the companies have bought different manufacturers, so they can increase their charge, because they own all the generic companies.
they actually, I was gonna say that, so a lot of the, don't be fooled, a lot of the brand name drug companies also happen to own the generics.
Yes,
Okay, that's a different problem all in itself.
oh, yeah.
But what I'm getting at is that the formulary that you guys have is relatively open.
So then it needs to be a little bit more narrowed.
We can do that and it'll save money. You'll see more generic,
Just don't do what Wesco is.
but here's the problem.
Nothing's.
We were approached by ESI not too long ago. When Gonzalez and I were on the phone with ESI, they noticed the generic fill rate. We started having conversations with them, again, in an attempt to cut this off at the pass. But then you have to say, okay, well, if we start making, we can get really aggressive and do mandatory generics, or we can change the copays to 0 and funnel everybody to generic and see how much that costs. Or you can start asking people to do a prior authorization. So before they go to the most expensive drug, have you tried some of the lower cost expensive
We
drugs?
don't have that currently. I thought we had where you had to try the generic, and then if it didn't work,
Angie, you had that in the past, it was step
It's
therapy,
a step edit, but you have to, you know, show that you
correct?
used it.
The only
'cause-
thing is that if they had gone through step therapy when we were with UHC, then they didn't require it this go around with ESI, because we didn't want the employees to have to go through it all over again. But
Disruption.
I know ESI did recommend that they go through it all over again for with the new carrier, but we didn't want that disruption with the employees.
So what
Especially
we,
because some had just gone through it.
It's
But
like,
that's
let's
what he
say,
said, like
you
a
know,
real-
I prescribe a blood pressure medicine, and it's generic, lisinopril, it's been around for 40 years,
very cheap.
and very cheap, and then they get a cough. Okay, so I have to use different medication. They're all generics, because I mean, most of us providers, we always use generics because we don't want to get those forms and the phone calls, and the patients are out of, their blood pressure is 200, and they end up in the ER every 4 or 5 days, and they get CAT scans. And so you don't want to have them off the medication. And you just document, you know, they've had a reaction, so then you go to the next class. And most of those are generic now, the ARBs,
A lot of
like
them are.
Benecar, and all those are generic. Or calcium channel blockers, they're all generic. And there's a few new ones that are pricey, but they're for heart failure, and Entresto. I mean, we have had so many, the ER rate goes down, the cardiology visits, the echoes, the costs incurred in caring for those patients offsets, and their quality of life is better. They're not gonna end up on oxygen and on dialysis, so. But, and most providers that I've worked with, or that, you know, we're in a group, we try to use generics, because otherwise we get those forms.
And they're a hassle.
And the prior auths it can take 2 hours for one prior authorization
So what
per
would we,
patient.
so what
We
we
don't
do,
have the staff to do that.
So when we talk to ESI, we kind of backed off of it, but what we can do is keep an eye on this, and then here's what we do. We ask them to model out, if we did the following, prior auth, step therapy, mandatory generics, whatever we decide we're gonna do. We can either go baby steps, so it's not, or do we take the approach to be aggressive, and that way the employees are at the max, and after a year, they start to comply anyway. But we wanna know how much money is it gonna save us, and how many people are gonna be adversely affected or negatively, or positively affected. Because some people will be positive because it changes the tiers where drugs fall into also. They can go from a lower copay to a higher copay, or go from a higher copay to a lower, or now have to get a prior auth and not get the drug anymore, which,
Yeah.
and they usually find out at the time of service, which makes them upset, because then they can't walk away with their drug. But you wanna find out how many people. So if the savings is really big, and it's not that many people affected, there's no reason why we shouldn't do it, because we can preemptively send letters out to these employees to take to their doctor to say, hey, it's gonna happen in 90 days, you don't do it right then and there. Or is it not enough money and a bunch of people and it's not worth the noise? But the noise from the employees versus the noise of the cost. That's the delicate balance we would play.
The other thing we see also with prior auth is the pharmacies themselves don't like it. So sometimes they don't call in the prior auth to the doctor and the script just sits. And they'll tell the employee, it needs a prior auth, we're gonna wait for the doctor to call us back.
And they never send it to us.
And they never send it to the doctor, because
I hear that all
it's
the
work on
time.
them also.
Yeah.
And then here, the employee's waiting and waiting and waiting, and they don't have their meds.
You know, some of
So
these,
it's on both ends.
yeah, some of these, branded products, the companies, because I'm always complaining, the district manager comes and they're, you all need to work with, helping us, you want us to prescribe it and the patient has to pay such a high price, so they come out with copay cards that will actually cover, like some of the diabetes drugs that are expensive, Farxiga and some of the pharmaceutical company will pay the pharmacy the difference and apply it towards their deductible, but the techs do not want to process those cards.
Gotta be careful with those cards and coupons, because here's what's really happening. So let's say the copay is $75 or $100, and they say, hey, we're gonna give you this coupon, and now you don't have to pay your copay. Behind the scenes, what they're doing is when they scan the coupon, they're just increasing the price of the drug by the $100, and the district ends up paying for it.
That's the
Instead of the-
pharmacy, right?
That's the pharmaceutical company who's giving you the card. So you're talking about, okay, I see what you're talking about, the membership like at Walgreens where you pay $20 a
No,
month?
these are like, the cards. So next time,
Okay.
because, first, the pharmacy doesn't want to activate, some of these insulins, sometimes there's just like one insulin or 0 insulins that are covered on some of these plans. And a patient is running 300 and they've already been to the ER twice and they're gonna get they already have retinal bleed and their kidney function is dropping. I mean, you can just foresee this person's gonna need a shot every week with the
Right, because
and with a retinal specialist, and that costs thousands and thousands a month just to get those shots. So you're like, okay, what do I do with this individual, and so you try to find ways to help them. But we also need to know on the other end, and the pharmacist is, the techs do what they wanna do many times, and the pharmacist has no clue.
education all the way around.
Yes.
That's where you need to be the investigator.
Start going to the pharmacy.
Run up,
Hey.
Yeah.
well,
You- like
we
a-
do.
What do they call them, a secret shopper, where you go
A
in
secret
and-
shopper. Because how else are we to believe,
Correct. Well, and that's another thing too, so just like the medical plan, when we hear of pharmacies like this, we wanna encourage employees to let it be known, because those pharmacies are on that PBM's network, so if they're not doing what they're supposed to be doing, then we let the PBM know, just like if the doctor was not behaving in a way that we think that they're, on Blue Cross, or in this case, ESI would approach the pharmacy and say, we're getting a lot of complaints for this, and that. If you wanna stay on the network, then we need you to, these need to be resolved.
But probably what's gonna happen is if I'm the customer, I don't have to pay, so why should I worry about it? So that won't work.
We need to educate. But we do need to find out which pharmacies are, where the
They're all-
problems are.
the same text jump around.
So if we flip the page, just real quick, look at the utilization, the plan cost by indication, look at where diabetes. It's above cancer.
What page is it?
Just flip the page. And even more interestingly than that, cancer's not number one, it's not even number two. The anti-inflammatories are. Those are the ones you see on the PGA. The golfers saying I use Humira or Enbrel and all this for the
Yeah,
and methotrexate has been around for a long time, but you know
but you can't take it that long, not for psoriasis.
because you have to take the is it their kidney damage or
It causes liver damage.
liver damage? Sorry,
I can speak from experience, I was on it for 5 years,
methotrexate,
methotrexate.
self-administered injectable.
No,
The
pills.
pill. But look at where diabetes falls. So now we're talking about by indication, okay? Not by, so cost, diabetes. And I was talking to the superintendent earlier, this is the diabetics that we know of. So we also need to run a report to say how many of you are getting your routine annual exam. And even that isn't enough because once they get the exam,
What are they doing?
are they using it?
The
Are they
ret-
compliant?
The retinal exam? Or what did you say?
Just the full, their routine annual exam, their general health panel, draw blood, all of that stuff.
Some of them do, but,
Remember, that's covered by
and
100%
it's covered 100%.
once a year. Okay, so we need to start looking
So how
at,
do you assess that? I mean, do you have an analysis of how many are getting their annual exam?
we can give you a number. Here's the percentage of employees that are doing their routine annual exam. And then we can take it a little bit further. This is an add-on that we might consider Blue Cross doing. And this ties into wellness, where they start tracking this stuff, like a disease management program. And they'll actually go a step further and say, here's the newly diagnosed ones that I see those, that ESIs will send us a report, are they filling their scripts and injecting and testing? Because if they're not, then there needs to be outreach to them. What is the problem? Did you not understand? Is it money? Find out what the problem is to get them to start.
Well, it's, those
being
numbers are, about filling the prescriptions. I mean, with so many other insurances, we have to hit 90% on our patients. So the girls are calling them and we're doing 90-day prescriptions and, you're babysitting, but,
You can't make them do it.
you can't
And
make
they won't
it.
answer the phone sometimes.
Well, I've started with Health Springs, they're really strict. I mean, if you don't make your percentages, you're not paid.
So here's some ideas. You've heard of the stick and the carrot approach, right?
Yes.
So the stick would be, before, if you want to enroll and you want the contribution to stay the way it is for you as an employee, we do that at Gallagher. Then you need to do your health risk assessment, followed up by your blood work within 90 days of coming, or somewhere along, maybe 6 months, because not everybody does their right up
You
front.
don't wanna.
Or your contribution goes up by X, because you're not taking an active role,
Yeah,
And they can go to their family doctor to get that done.
and it's 100%.
yeah. And it's 100%. I mean, and it's just blood work.
Now, I can speak from experience, because here I am saying this, but I was one of those guys that never went for a long time until my employer made us do that if I wanted to keep the lower deduction. And when I did go, which is what most people say, most people have the idea that if I go, they're gonna find something. I know they are, and I don't want to deal with it right now. Ignorance is bliss. And I got a call saying, hey, you're what is the fat in the blood? No, not
Cholesterol,
no,
triglycerides.
triglycerides. 700.
Oh my God.
They said, what are you eating, a bucket of chicken every day for the
That
last
was
2
your
weeks?
triglycerides?
Where's my triglycerides?
You know what your blood looks like when they let it sit? Manteca.
You know what he told me? He goes, do you know what triglycerides are? He goes, that's the amount of fat in your blood, or in your case, the amount of blood in your fat stream, because you have a lot of it in there. And I didn't know.
It comes out real thick and milky.
I didn't know. I'm at 150 now.
Manteca.
But I wouldn't have known had they not made me go.
So you had a heart attack
Or even worse.
or died?
Yeah.
Yeah, it'll cause a massive heart attack.
And it scared the heck out of me.
Now I'm thinking I should.
Well, that's why they say, they use that tagline, know your numbers. Do you know your numbers?
I immediately started doing what I had to do today.
Anyway, so we're kind of getting off but
But if that's an option to help keep, I mean, it covers
So,
This is not an ACO Blue Cross, is it?
no, but
Because I know
ACOs,
2 years ago, Donna Izzy had an ACO Blue Cross. Okay.
so we'll talk about ACOs, HMOs, and EPOs and some of the new,
No, it's because they had measures
yeah.
and they would call.
Well, that's what I'm saying, ACOs are accountable care organizations, and as she's speaking to, now the doctors and the hospitals had skin in the game, where if they diagnosed you, it was their job to make sure that they continue to hunt the employee down, teach them, educate them, because they get paid based on outcome, not as they provide a service.
Right.
And it's in their best interest that they have a positive outcome, because then they get to share in the savings. And so two things can happen at the end of the year. Austin ISD's on one. We're kind of getting in the weeds, but I'll just kind of go through. Austin ISD has one, they either get a check written back to them because they didn't meet their target, or Austin ISD pays them gladly because they shared in the savings. We've got a lot of ISDs that are moving to what they call ACOs, but that's a different discussion. So I'll kind of go through this the rest of this kind of quickly. Utilization summary, look at specialty. That's another one. Specialty drugs, 30%, 69. Non-specialty, specialty drugs are the ones that cost a lot of money. Harvoni for Hep C, $40,000. You have to take it for 3 months. There's a new drug that came out, I don't know if the FDA released it or they just did. It's for infants. I can't even pronounce it. It starts with a Z, but it's $2 million. And so that would be a specialty drug. So this is the split. Specialty drugs drive a lot of the pharmaceutical costs. So we look at those carefully.
And we also, I noticed we had HIV on there.
We do. And so those are gonna be long-term, when you see those on there. Okay. So let's talk about the last thing here. I talked about run out with United Healthcare. So I got a little bit of bad news. So with United Healthcare, they're continuing to do the run out. If you recall, we did when I came on board, you guys had changed, when you guys awarded the contract to UHC, it was for a full 12 months. And then the decision was, let's make it a short year so that we can change the effective date to match the ancillary coverage. And then when we came on, when we awarded the contract, we were told we gotta put this out to bid, and we weren't gonna have enough time to do the RFP or do the implementation. So we asked UHC to put it back to a 12-month contract, and then we'll do a short contract. And so that's when we learned that we needed to get the copies of the stop-loss contracts from United Healthcare. The United Healthcare stop-loss from your previous consultant, the way that they did it, there's various schools of thought on how you do stop-loss. We do it very differently. But what they did, and I'm gonna get technical here, so it might not make a lot of sense, I'm gonna do my best to explain it, but without getting too in the weeds. They added what they call TLO, Terminal Liability Option. And basically what that means is that after the expiration of the term, because you did term coverage to move to Blue Cross, they would expand the stop-loss insurance for additional 3 months. Okay? What that also does that we didn't see in there until they explained it to us, because it's not in the contract, but they said it was in the RFP that was approved on the contract. And then I kept asking, well, who was the consultant, and they weren't sure. I had to talk to Angie. Was it Pete Hamarillo or was it Holmes Murphy? The person that we were working at United Healthcare left, so 2 other account managers had to look at it and do some digging. But here's what we're doing. So when you terminate, it automatically activates the TLO coverage. Okay? And so what they do is that now instead of 12 months, they recalculate your factor, your maximum liability, on 15 as opposed to 12. I mean, it's a necessary evil. You gotta have the stop loss coverage to pay for the run out. When they did the recalculation, that changes your maximum liability. Prior to that, or somewhere in there, we're thinking it's September or August, we need to check with UHC. You had an ag violation, what they call a trigger. Meaning that you paid the maximum amount, now they're on the hook and they have to pay the rest because that's what your target was, based on the 12-month calculation. And so they've funded your account, $419,000, because you paid what you were supposed to pay, and They're supposed to pay the rest because that's what the contract said. But once we did once the terminal liability option was executed, because we moved to Blue Cross, they add an additional 3 months and they recalculate it. When they do the recalculation, that trigger wouldn't have existed. And so they're going to recall that $409,000. And it's because of the TLO option. I've talked to them. I'm continuing to discuss that with them about the language. I'm asking them to spread the $419,000 over maybe 2 or 3 different payments instead of one lump sum payment, but that's because it extended the stop loss protection. The other thing I wanted to let you know is that the only way that you wouldn't have paid that is if you would have stayed with United, because if you would have stayed with United, the TLO doesn't get executed, they keep the stop loss and they continue paying.
And that was on the contract
Correct.
for
United Health.
United.
Correct. And it was put in there
Could
from
you-
your prior consultant.
Could you give us a copy of that particular
Absolutely.
statement?
They even include the calculation.
And then exactly who was the consultant at the time?
United Healthcare has a different name than what we think it was, but we'll give you one or the other. They're saying that it was Pete Jamarillo. From the recollection here, that it was Holmes
So
Murphy.
our consultant, Jaramillo was our agent of record, our consultant was Holmes Murphy.
Now, I wanna say, it's not that it was, anybody messed up. Again, there's different we don't use TLO the majority of the time. What we do is we'll ask, if we're moving over, we'll ask the incoming stop loss carrier to do a 2412 to cover it. If we would have done 2412, now we have duplicate coverage because they had the TLO on it. And here's the other thing, most of the time, it's extremely rare that a group has an ag violation, because that means they misjudge the target, the claims. Doesn't happen very often, but it can happen. In this case, it did happen to you all. The difference in premium, just so that some level of comfort here, the difference in premium from Blue Cross to if we would have stayed with United Healthcare was about $700,000. So it's gonna water down that savings by about $400,000. But the bigger picture is that if we would have stayed with UHC just to save that $400,000, but we wouldn't have known then anyway, because the trigger had already happened and we didn't go beyond the 3 months. If we would have stayed with UHC, it would have cost an additional $9 million in claims. So we still made the right, it doesn't affect the decision that was made. What should have happened though is, had we known ahead of time that they were gonna do that manual calculation, it would have been helpful, but even then, we don't know when that claim's gonna hit. It could have hit and it could have not hit. And the other thing that I recall is that, and Angie, correct me if I'm wrong, prior to last year, UHC had like 7 people lasered out of your stop loss coverage. Which means they said, these people are so risky, we don't even wanna take the coverage, you pay them, and here's a lower premium in exchange for that. And you went with that, so it means you guys paid all their claims, regardless of how high it went. This last year, or previous year, they removed those lasers and put them back in, and I have a feeling that's kind of why it went so high up as an ag violation. When Blue Cross submitted their RFP, they initially lasered them, if you recall, but their rates were very competitive, and so we asked them during the best and final to reconsider, and they did remove the laser. So it's basically just a different school of thought on how you set up stop loss, and every consultant does it differently. But every stop loss company also calculates that TLO very differently.
So we were actually saving almost $500,000, but now we have to pay 411, so we're back to zero, basically.
We were gonna save 7, we're gonna probably save.
568.
Yes. Well, the difference in premium was like 700,000. It's on a different slide. It was on the best and final presentations that I came and did when we voted, because we did a side-by-side comparison. But the bigger thing is that the claims, had we stayed with UHC, you would have paid $9 million more. But there was no way, you can say, well, if we would have stayed with UHC, we would have avoided paying the $400,000, but it would cost you $9 million more on the total picture. And there was no way of knowing at that time that there was gonna be a trigger.
I'm just focused at the end,
I understand.
minds are the savings.
You're talking numbers.
A dollar savings, a dollar savings. That's the only thing I've got
And
my
this
focus
was new,
on.
I was sharing with Lou that when we went, when we were with ABA, and we went back to Blue Cross, I don't ever remember
TLO.
having to deal with TLO. And then when we went from Blue Cross to UHC, the same thing. I don't ever remember us having to worry about TLO. This is the first year that we would ever even hear about it.
We don't tend to use it very often. The only time we think it would be beneficial, which doesn't happen, but we do have a precaution, is if you were fully insured and you're going into self-funded for the very first time, and then after a year, like you say, I don't like this, so let's go back to
So
being
you don't,
fully insured.
you don't have it in your current contract? do
Oh,
you?
no, we don't use it.
Sure.
And when we put the stop loss out for bid this year, we don't ask for TLO as an option. We'd rather go the route of the 2412. It does cost more, but we like using the 2412 as opposed to the TLO option. Again, it's just a different school of thought on how you're gonna use the options that are available. So I wanted to make sure you guys were aware of that. And I'll keep in touch with the superintendent and finance on when they plan on doing that. Other than that, I think I've covered all my slides. And I did take notes on how you would like to see last year versus this year.
I mean, one thing we've asked also in the past is the ER utilization.
So even more specific than what I gave?
Not names, but just, how many, if there is a way, and it's all based on claims paid. Which ERs, and, because that's a
That's
big
good.
So
like
here
that.
I have,
driver.
here I have the ER visits and their ICD-9s, so for what they went for. What I don't have here is names or the facilities.
Actually,
No, we
they can give it to us by names also.
Well,
No,
that
but
would be.
Not
Locations?
patient names.
Oh, not patient names.
No.
You wanna buy the
Facilities.
facility name?
Facilities.
I can do that,
Facilities.
I can do that.
Yeah,
And the costs. Like how many
I have
of
the
our,
costs here,
oh, okay.
I think by
facility.
location,
by
facility.
location, so you can see the
Yes.
differences?
Yes.
Okay,
To see which ones are
sure,
good.
I can do that.
No, I thought it was,
It was one about the hospitals, I think, but it
there was
was.
one about the hospital.
The one about,
On the hospitals, we did provide names,
exactly. You have it.
Yeah.
I think on outpatient, so you would like to see that on the emergency room as well.
Yeah,
Okay.
that's good.
Yes, here, ER facility, okay.
What page is that?
It's on
16?
16.
15 has the name of the hospitals.
But those are
But
for
see, here it's
inpatient.
like, okay, so that we can see which ERs they're going to.
And the cost.
And the cost, because I know South Texas is one of the costliest,
They're very expensive.
very expensive. I mean, you go for urinary tract infection, you're gonna end up with a $10,000 bill and they don't even do anything.
Oh my God.
Because they put, like, they checked you and they put a complete review of systems and they checked your ears, your throat, everything. And the patient says, they didn't even touch me. They looked at me from the door. I says, well, you need to call the OIG and complain.
ER visits and inpatient hospital stays, that's not uncommon,
They just
you know.
check people from the door.
You think you walk into the ER and you're only gonna get the ER bill, but then you get all these other bills, the doctor that you didn't see, but they read your chart, or the emergency room, the radiologist, the
Well,
anesthesia.
radiologist say report them.
But I can do that by name so that you can identify which ones they're utilizing, and then we can zero in and see how much their cost is, but in
And,
the end, what Blue Cross is actually, because they get a discount, right, they get to see what they're actually paying for those services, in comparison to the others. Okay, sorry I took a little bit longer probably than you wanted.
When will we have a next meeting?
So what we can do is, we can do this exercise monthly, but it gets a little redundant.
No.
I like to do
maybe
it quarterly. Every 3 months?
Quarterly, I think
Quarterly.
quarterly works good.
So that means I'll have January, February, March, so we'll do it sometime in late April or early May. Because there's a little bit of a lag, so I'll have January, February, March, I'll have March claims April 20th. So we won't be able to see it until May.
See, like here, one of the ERs, 17 ER visits, $32,680.
Not cheap.
34 ER visits, 30,000. 21 ER visits, 27,000.
As far as next step, you mentioned something about the pharmacy or pharmaceutical costs, or you're gonna do some analysis?
Yeah, we're gonna look at, I guess we can take another look at with ESI to find out, get them to model out maybe some more options on either step therapy, mandatory generics and stuff like that to see what the cost would look like, and then they can show me how many would be disrupted. And then you can look at cost versus how much noise is it gonna create.
And is it legal to put up like providers?
I'm sorry?
Providers, like which ones, I guess with the
Who are,
insurance?
who are prescribing those drugs?
Yes, when we meet with our, like in our ACO and our Take the House room, they put everybody, it's full you're costing us this much, cause you're doing so much DME or home health, or you're, they're just recertifying and not reevaluating the patient, I mean, your name's up there, everybody's name's up there, but you can't do that.
I don't know if we can do that, that might be
No,
getting
it's
to,
okay.
yeah. We have to be careful,
I
you know,
mean,
walking
I'd
a
like to
fine
know
line.
if it's me, cause I know I put generics on it. I've only written 2 brand on thyroid because she was in there every 2 to 3 months. And repeated labs, and when you think, okay, is it more cost effective to put her on the brand name? Cause some people, they get a different pill every time they fill the prescription. There's so many different generics. I mean, it's a blue pill one time, and then it's a white one, and then it's a pink, and
By the time I come back, I'll also be able to tell you what you would have received your rebate check by then, but we can disclose what the first quarter's rebate looks like.
Do you think you can still bring us at least a $1.5 to $2 million savings, reduction in costs?
Wow, just like that?
No, I'm basing it on like the current savings for the first 3 months, well, we're back to 0, but it's about $500,000, so I'm looking if trend repeats, that's about a $2 million.
If we have the same behavior, again, the crystal ball, the one thing we can't.
if the behavior of our citizens in the whole valley doesn't change, I mean.
That's the one thing we have no control over, right? Is
Our
how
hepatologist
utilization.
is just so busy because of the foods they eat.
I'll try, I'll do my best. I mean, that's our job.
Everybody needs to be active and they need to eat healthy.
I
That's what we need to do.
Yeah.
I just, like I said, that happened to me about 12 years ago, but ever since then, I mean, I'm not saying I'm the healthiest in the world anymore, but I certainly go get my routine annual exams.
It's a work in progress.
At least it's going to.
I was like, ooh, I don't know my numbers.
Is that it?
Yes,
That's it?
all right,
That's
yes,
it?
that's it, I'm sorry it took so
Thank
long.
you.
These will go faster the next time, because we kind of already know what we're looking at.
Thank you very much, I greatly appreciate it.
Taking medication.
Oh, yeah.
Any-
Anything else?
This food,
Oh, they're over here. No.
Y'all already ate?
And we're gonna go eat it here. No, just kidding.
But not anything clinical.
We had to do 3 body part x-rays. I'm like,
The only thing I want to focus is, I don't know if I should just get a head continue. Or just change, or,
We've already asked them, we
what
asked
they
them every
say,
year.
they say no?
it's almost hard, right?
They can't do it, ever since because we had that fight here for years.
They didn't do it when you had to the last time?
And we've been there, we've been since 2014.
I'll try.
And they said that they were built for 4. Bye-bye.
We have new management.
Okay, well, thank you. That would help.
It would help us.
Because we had to do it manually every month. They would
We-
have to
And
go
then we
in
would
there.
have to do it.
Yeah, and
See you
so.
Tuesday.